Welcome back to the podcast on non-interpretive skills in radiology. My name is Nadia Kedem, and today we're continuing our discussion on IV contrast with Matt Zygmunt. Let's dive right in.
So I think the point that I leave with the residents who are listening, CT contrast in general is pretty safe. If the diagnostic benefits are there, you can feel okay about giving a contrast dose.
Yeah, thank you for that background. That's very helpful. I think there are some acronyms out there that are worth talking about that relate to what you just explained. There is the term of post-contrast acute kidney injury, PC-AKI,
Right.
and there is DIN contrast-induced nephropathy. That latter one, the contrast-induced one, is almost like a statistical concept. It's like the very rare cases where you can prove that the contrast itself led to the kidney injury. In truth, there are other factors that put patients at risk. For example, if they have diabetes or other underlying conditions, then it can be more likely that causes the kidney injury. So if they're dehydrated, they have cardiovascular disease, they use diuretics, they're older patients, they have multiple myeloma, hypertension, hyperuricemia. All of those are risk factors for this acute kidney injury that can happen after contrast was injected, but that contrast is not necessarily the cause of it. And the other interesting information here is for patients on dialysis. When the contrast is in the system, it doesn't do further damage. So you don't really have to time anything with the dialysis. Whenever they have their next dialysis is fine.
I mean, that's an important concept. And I don't think the residents realize that. We fought this for the longest time with our group practice because we used to have this concept among the technologists that if you injected a patient on dialysis, they had to get to dialysis within 24 hours. That's not the case, right? Our injections, let's say you're doing a PE study, is going to be 60 cc's of contrast, maybe a little bit more if the patient's larger. And then you've got a pre-flush and a post-flush. So max total volume for that whole injection is probably not going to be more than 150 cc's. And on a percentage basis for the total blood volume and the interstitial fluid of that patient, it is such a small fraction. So by giving one CT exam, you're not going to push this person over into pulmonary edema. And I think that was always the concern. So we no longer, they're on dialysis, they get their scan. And we let the medical team know that this patient is on regular dialysis and they know how to monitor their fluid. If anything, they probably need to adjust their intake for the injection. And we let them know that how much fluid they get, but they don't have to schedule another dialysis session because they're getting a CT scan. That's helped tremendously. And I agree. It's a super important distinction of what is the causality of a renal injury and what is the likelihood of any particular renal injury being permanent. And the data, as far as we can tell, seems to show that the agents we're using now, when injected intravenously with CT, are probably not causing kidney injury. And if they are, it's very minimal. And the vast majority of those injuries return to the baseline. So the bottom line here, I can't stress this enough. This has been a really hard concept to get everyone to get behind and give consensus to the techs when they call for support. The bottom line is that the contrast agent that we're using, Omnipeg, is considered safe. And I would love it if we, in our institution at least, moved slightly away from the conservative position where the ACR is, and we loosen some of our screening processes because it causes considerable delays to wait for point of care, wait for labs to come back, especially when in the end, it's not really going to matter.
Are you saying if the eGFR is less than 30, for example, you are less concerned, or how does that relate to the eGFR?
No, that's absolutely right. And there's so much recently with how do you calculate estimated GFR, and all of the original data from that Mayo group and the Michigan group was using the MRDR equation. And we know that there's issues with that in terms of accurately measuring or accurately giving an estimate for certain individuals based on their race and gender. The MRDR seems to be overly conservative, if anything. But yes, if let's say they call me and you're on clinical service, they say, we need a dissection protocol. This person's got a GFR of 25. I don't give a lot of pushback. And the reason is because we don't, at least based on the data, the risk estimate is super, super small. It used to be that would be a hard stop for many people. And I think now the answer needs to be, no, it's not a hard stop. And the safety profile is at a point where we can use it with confidence. And you're not going to do lasting damage to this person's kidneys.
That's great information. We actually still at my children's hospital go with this, whatever is in the ACR guidelines, where it says under 30 ml, you should avoid giving IV contrast unless it's absolutely necessary. And
Yeah.
then if it's between 30 and 45, you think about the risk benefit ratio. And if it's over 45, you just give it and it's fine. But thank you for that update. I just want to caution everybody who's listening, if there are still exam questions around, they might rely on these old cutoff values.
Yeah.
And so it's still good to know.
Yeah. Keep in mind, if you read the ACR, I don't think they have those 3 buckets. They just have a biphasic decision point around 30 when you look at it. But I encourage you, right? You read the ACR manual and all of those references for those original studies at Michigan and Mayo are in the citations. It's worth looking at and really doing the deep dive, especially if you're in a quality and safety role with your group. It allows you to do things like not restrict contrast dosing out of the ED. You don't want to be overly restrictive to the point where it creates a bottleneck for your workflow. I don't think this is cavalier in any way, right? I think it's just using the data to make an informed decision about what's best for your healthcare system in general. And I don't think you're actually creating any excess individual risk based on those numbers that you look at. Just to be clear, we do have a checkpoint, right? There's a hard stop at 30. So if your estimated GFR with our physician group is 30, you get a phone call and you get to decide. And my comments were just that depending on the situation, I'm more inclined to inject than not.
Okay. Then the other thing that always pops up is when the patient is on metformin. What do we have to consider with a metformin and IV iodinated contrast?
Yeah, so this seems to be less of an issue now than it was previously thought. If you have depressed renal function and you're on metformin, you're at risk for possibly developing lactic acidosis, right? And the issue then becomes, okay, so this patient has a certain renal function. They're on metformin. What do we think is the likelihood of us giving them contrast and their renal function being depressed enough that it puts them at risk while they're on the medication? And the answer is it's very little. So it used to be that we were doing all these phone calls, calling the patient, telling them to stop their metformin, having issues with blood sugar control. Now we say you can stay on your medicine, you come in, you get your injection, and we will check a creatinine to make sure that it's within range. And if you're above the 30 cutoff, we let you go. You're not stopping your medicine. We're not checking another creatinine. We feel confident that the chance of you getting a hit to your renal function to the point where it pushes you into lactic acidosis with metformin is super, super low. Now, that being said, our process has changed. If you're below 30 and we catch patients that probably shouldn't still be on metformin, then we'll just pump the brakes and their primary care doc gets a call. So that's the distinction, right? We're basically a secondary screener for saying, hey, you probably shouldn't be on metformin because your renal function isn't enough. And we'll usually wait to do the study until they get a medication adjustment. So huge change in how we think about that from 10 years ago. And again, I haven't had a safety event in 14 years of a patient on metformin who developed lactic acidosis after a contrast injection.
Yeah. I think the risk is really only for patients that already have acute kidney injury, or they get maybe, say, an angiogram of the kidneys where they could get kidney emboli causing acute kidney injuries. So those kind of circumstances.
Right. Yeah. I think the whole situation changes when you're in the aorta and you're crossing the renal arteries with a catheter. But for IV injections around CT contrast, I think that the data is robust and it's strong enough for us to make these kinds of policy adjustments that walk the line between allowing patients to have the access they need and not placing anyone at excess risk.
Right. Now, before we talk about contrast extravasation, just maybe some quick words about iodinated contrast in pregnancy and breastfeeding.
We work at a level 1 trauma center. And if we're going to scan a patient in the third trimester, we scan a patient in the third trimester fully. And in general, we don't consider the CT contrast agents to be an issue. We will not use gadolinium, of course, in pregnancy. In terms of breastfeeding, same thing. You could tell them to pump and dump, but we generally do not.
Yeah. I think there's only 1% of iodinated contrast that gets in the breast milk, and it is metabolized in the GI tract. So there is no concern for that. I think we always recommend, if the mother is concerned, that they can just pump and dump, but they don't have to. It's only if they're concerned. Okay, so now contrast extravasation. That's more of a topic for CT contrast because we inject higher volumes.
We do.
Theory does also apply to gadolinium, but those are small volumes and they don't usually cause bad side effects. So extravasations are rare. According to the literature, it's 0.1% to 1.2% of all CT scans that have an extravasation. And we know that there are a lot of risk factors like a peripheral IV in the hand, the wrist, the foot, or an IV that's been in there for a long time, longer than 24 hours, a vessel that has been punctured many times. I think other things like patient age, other illness that they have, debilitation, stuff like that can heighten the risk of extravasation. So what are we concerned about when there is an extravasation? How do we know something has extravasated and what do we do?
Yeah, and this is something that we struggle with, and as getting consistent safety event reporting around this can be a little bit difficult. Our techs are pretty good at putting these in, especially at this hospital where I'm chief of service. Just to give you an idea, we're running 350 to 400 scans a day, probably half or 2/3 of those have some sort of injection. And I see anywhere from 1 to 2 extras in my inbox, each day. Some days there aren't, but 1 or 2 a day. So maybe a total of 10 a week, 40 a month for a site that does, what is it, like 20,000 exams. So
Yeah,
um,
volume.
I don't know that my math there was totally on point, but to your point, the rate is probably higher than what's published in the literature. And I don't know if that reflects a higher acuity care population in our practice. But I agree with you, right? Our techs are really good at keeping the IV at the antecubital fossa or higher, especially when we're doing a high injection rate with a CTA. And so many of our patients now, especially for trauma or at one of the stroke centers, are going to get a high flow exam with a CTA. That being said, kudos to the frontline staff that are placing this. I think experience shows if you have a nurse or a tech who's been doing this for a long time, they're able to establish a good IV. I will say that I think the most problematic IVs are the ones that are placed under ultrasound guidance.
Oh, really?
Yeah. I don't have real hard data on this because it's hard to collect, but the techs will tell you. If they couldn't get a stick, they place an ultrasound and IV. Those are the ones that inevitably fail. And if it's in the mid-arm there, the risk of having any kind of, tissue necrosis with a significant extrav goes down because there's so much more space in the fascia. You just don't want to pump 150 cc's, 200 cc's over the wrist in an older person who may have super thin skin, because then you'll start running into pressure necrosis issues. I haven't seen that in a really long time, maybe a handful of cases. over the last 10 to 14 years. So staying away from the wrist is key, and then making sure that you have the right size catheter in the right position is key. And it's great that our really seasoned techs have a lot of experience. They'll be able to look at something, do the test injection, know if it's probably going to work or probably isn't going to work.
The way that the techs find out that there was an extravasation is they look at the images that come up and they notice that there's no contrast in the vessels or in the organs. Or sometimes if they are not looking, when we interpret the images, we find out there was an extravasation and we don't see the contrast.
Yeah, but that's never the case because we do smart prep planning on all of our injections, right? Where there's a threshold trigger. For example, in the CTAs of the head and neck, they've got an ROI in the aorta. And if they're pressing go and they don't get anything, they start troubleshooting. So,
But if it's not a CTA, if it's just a regular post-contrast, whatever, mastoiditis protocol or something.
sure, where it's just a standard delay. Yeah, agree. Yeah, it just shows where we are, where trauma and stroke is so heavy. We have so many of these timed exams, but you're right with just the standard delay. But the techs are pretty good at looking at, the study and making sure it lights up in the right way.
Another issue that makes it difficult is when the patient is very heavy. So if there's a lot of fat, and with the test bolus, you can't really palpate at the injection site whether there might be an extravasation. That also makes it difficult to identify. And then I think the key clinical presentation is pain. And some patients don't feel any pain, but they
Yeah.
still have an extravasation.
Yeah. Yeah. The techs are usually pretty good at making sure the IV seems to have drawback and it flushes easily when they go to connect. We've switched over. Most of our injectors are now the new type that have the peristaltic pump versus the dual syringe models. And that switch has saved a ton of time and money and medical waste for us. To be honest, it's really streamlined our practice without, from what I can tell, causing any excess extrav events. So yeah, tough situation. And I think, Nadia, with sort of the high acuity type patients that we see, our rates are going to continue to be higher than what the nationally published average is. We're not just an outpatient only facility.
And then I think our standard approach to this is when it's a mild or moderate extravasation, it'll likely resolve itself. We recommend to elevate the arm, put some cold compressors on it. We report the event. The techs are supposed to follow up the next day because sometimes there can be a delayed compression syndrome if there's a small leak somewhere. And if it's severe initially, occasionally we may think about a surgical consultation. If the skin is really indurated and pale and we have a hard time finding the pulse, that might be an indication for surgical consultation.
Yeah, I encourage our residents at least to go and read the policy. It's been updated recently to shift sort of some of the clinical responsibility. They'll get an initial assessment in CT, but then if the patient is inpatient or ED, there's a clinical handoff and the follow-up is actually done by the clinical team. Since so few of these actually cause a problem, the patients are given instructions and they're told to call back if they develop any of the symptoms of a delayed response. But I don't know that we're actively doing outreach after an extrav anymore.
All right, great. I think we covered everything there is about iodinated contrast. Thank you so much, Matt.
Yeah, thanks. It was a pleasure being here. Appreciate the invitation.